Afternoon, everybody. I'm Gareth Frith. I'm the Technology Enhanced Learning Manager for the School of Medicine in Leeds, and I'll take you through some of the things that we've been doing using Myprogress and things like that. But I think it's worthwhile just starting off by a little bit of reminiscing of how we actually got here. And it must be about 6, 7, maybe 8 years ago. The UK government started a lot of centres for excellence in teaching and learning, so-called settles, and we applied for one with 5 other universities in West Yorkshire, the NHS workforce as it then was, and also a number of the different healthcare bodies and so on. So we applied for some money on the basis that we wanted to try and work out how to assess all different healthcare professions in clinical practice. And I think as part of that bid, somebody wrote one line in which said, and we will use mobile devices to assess these students and store the outcome in a portfolio. They won the funding, which I think was about £5 million, and then over 5 years. And then somebody said, how are we going to do this particular line that we've committed to in the bid? You know, so they went out and hired me and said, your job is to do that bit. And it's sort of grown from there. And one of the outcomes of all this was that the outcome of the settle was that you had to show how you were going to embed the actual work that was done by the settle into real everyday practice. And I think medicine in Leeds was the one of the 16, together with the Leeds University and the NHS workforce, and said, well, we'd actually like to do this for real with inside medicine. I'm not saying the other one wasn't for real, but you know what I mean. There was a lot of practice and finding our way in that. So we ended up saying, yes, we will do this in medicine. I thought, well, we need a portfolio supplier. My son at that point had a company with a school friend of his. They're both art designers, and they were sitting in the pub one night with me, and they said, and what are you going to do now, Dad? And I said, well, I'm looking for somebody who can do this kind of portfolio work. And Rob said to his friend James, well, James works for My Knowledge Map in York, that's what they do, isn't it, James? So it was very sort of, you know, there was no big, well, you know, eventually there was a tender process, but it was all completely by accident that we sort of ended up working with My Knowledge Map, and we rang up Rob Arnson and said, can you really do this? You know, and he said, well, this is the work we're thinking of. We need to do development around it, but you know, we're quite happy to share the experience and build it from there. So it's been going on for quite some time now that we've worked with MKM, and but it was a bit of a fluke as to why we ended up working together. And I'm not saying it was wrong in any way, but it was a useful collaboration. But it's just serendipity brings people together in this industry, and it was sort of quite interesting as to how we got together. So we started to do this in medicine. Medicine was a completely different proposition because whereas with ALPS we've been dealing with cohorts of 20 or 30 students and really, a small numbers of assessors, we walked into medicine and they said, well, by the way, we've got 1,250 students, 250 in each year, and this is a completely different scale. And I think the big experience that we've got out of this is that most people can do some of these things. This is commercial, academic, whatever you talk about. Most people can do a small project with a small number of people, but where it starts to become difficult and challenging and quite innovative is when you say, how do you do this with a large cohort of students? You know, and we're doing it with 1,250 medical students. You know, in the future, why shouldn't we be doing this across 30,000 students of any discipline in Leeds University, especially those who are, you know, think of business school, you think of law, you think of engineering. They're all going out and doing clinical practice of some kind or another. And, you know, the rules are slightly different, but the way in which these things start to develop is very much about supporting a clinical practice. So we started from that end and went out, begged, borrowed money to do various things. Some came from ALPS, some came from the university, some came from the NHS. And we really went around saying, this is a really good idea, will you buy into it? And fortunately, lots of people did buy into it. And we were able to then say, right, we're going to give a mobile device to all our 4th and 5th year students. We're going to look at how you start to use this across the fact, you know, the actual curriculum for medicine. And you know, these are some of the challenges that we were looking at. Medicine's quite different from a lot of subjects, and similar to dentistry, similar to a lot of the healthcare studies. But you know, students don't spend a lot of time with us on campus, so we don't see them very often. The days when we do see them, you know, the med school cafe is heaving to the doors and you can't get your lunch, you know, but most of the time they're in clinical practice. They're trying to work with patients, with doctors, with nurses, you know, and trying to learn about their future profession that way. Also, you know, things that we found was that the hospitals are changing a lot. You know, the big impetus from a hospital perspective is not to keep people in hospital anymore. They are trying to very hard to get people out of hospital. Well, cure and fix them first, you know, but they're trying not to keep people in for long extended stays in hospital. And typically in the past, students have been, when somebody's in for a long period, the student could follow that particular case. Whereas now they find that, you know, they see a particular case and it's a patient who's only in there for a couple of days. They may not see the outcome of that case. They may not be able to follow it through. So things are changing in that workplace quite dramatically in terms of the students looking and observing specific conditions. Also, you know, there's an enormous emphasis on the whole idea of patient safety within medicine and within hospitals and so on. And if you think about what it is to become a GP, for example, today, you are running a small business. You're not just being the local doctor. You know, so there's a whole set of things that we need to start teaching our students that are about becoming a professional in medicine, but not necessarily are medical. You know, so patient safety, professionalism, running small business, all those kind of things. And we were, again, around about the same time, we were looking at the whole curriculum of undergraduate medicine and saying, you know, how do we redesign that to meet those new challenges? So it's still a 5 or 6 year course, but we did launch a brand new curriculum in 2010, which is 5 years ago. And as part of that, we underpinned the whole thing with learning technology has to be important in this, both for contacting our students, looking at the way students are learning, putting the whole idea of learning in clinical practice into their hands rather than ours. And I think those are the principles. So we were able to coincide with the new curriculum and start to introduce this the idea of technology enhanced learning. So, as part of that, we designed two new courses. One called Ideals and one called Res. Ideals is the professionalism side, and Res is the research side. Because not everybody doing medicine wants to become a doctor per se. They might want to become a medical scientist, and they might want to follow a research route. So, for the first 3 years, Ideals and Res are a longitudinal stream that goes through the medical curriculum and is about teaching those non-scientific medical things that people need to know to survive in that profession. The other thing we did was drastically increase the number of clinical placements that our students do. So instead of going to medical school for 3 years and learning all the scientific stuff, and then at the end of 3 years going out and doing clinical practice, we started right from the beginning. So first term, first year, student goes to see patients in their home, takes histories, they get involved in primary care and so on, and it increases. And in year 3 they are now doing 4 days out of 5 in clinical practice, and that continues right through to the end. So big change there as well. So we're really trying to respond to those changes. Now, in the early years, we worked through a whole area of small group teaching, so that the students are taught in groups of 12 maximum. So we have a lot, for 250 students, that's 12, 15 groups that are being taught in parallel at any given time. Ideals and Res do that way. Ideals is innovation, development, enterprise, leadership and safety, and then Res is the research and evaluation special studies stream. So those are taught, and the portfolio is an integral part of that teaching. So, I had a year 1 group a couple of years ago, and every Friday morning we sat down and we worked through a particular problem on the Ideals curriculum. I would set them an exercise in the portfolio. They would complete that exercise within the portfolio by about Tuesday or Wednesday the following week. I'd spend Wednesday evening laptop on my knee giving them feedback into the portfolio, and then by Friday morning we could then pick up that feedback and discuss it and then move on to the next topic. So that's the sort of way in which we use the Myprogress for small group teaching. And it is longitudinal over 3 years, and it's essentially formative, but what we do is at the end of each term there's a sort of passport session which the students have to pass to move on to the next term. So it's about reviewing what the small group teaching has done with them, making sure that they've answered all the tests and quizzes that we've set them, and the portfolio and Myprogress has been really useful in driving that forward. So that by the end of the term, the student could come in with all the evidence of what they've been doing within that term of Ideals or Res or that side. And in order to help that, we commissioned the first part of peer feedback, which essentially supports this idea of passport for progression. And the functionality, we set it as an exercise within the portfolio, and then that's sent to, say if you've got a group of 10, it's sent to nine other members of that group, and they can give feedback on that, on the blind feedback on the other member of the group. But also what we do is to sort of perhaps on feedback on presentation skills participation in the group, so you can set what you like in that. But what we also do is that the student can also take that quiz as a self-assessment. So you can then say, the student can say, well, I've done it as a self-assessment, this is what I think. And the other 9 can be pulled together and say, that's what they think. And then there's either a good match or there's quite a big delta between those two. And that's the kind of thing which would then get discussed at the passport meeting. So that's how we've used the peer feedback, and I think this is the first year we've used it. I think so. We'll probably refine it next year and move it from there. That's only online at the moment. So what I'd like to talk about now is the mobile work that we've done. And that is the map of where all our clinical practice areas are. So we've got Leeds, lots of big hospitals in Leeds, Wakefield, which is Pinderfields, and Dewsbury, and other places in South Leeds. We've got big hospitals in Calderdale, which is Halifax, Huddersfield, Bradford is a big teaching hospital, Airedale is another hospital. So, it's not a one-to-one relationship between the medical school and these teaching hospitals. We have lots of placements. On top of that, there is a whole set of community and mental health trusts, which we put students go to. And also there's 140 primary care GP practices that our students go to. So, it's quite a big geography in terms of working with the students in placement. And I think we went for the idea of mobile partly because we tried to do this with Alps, but the technology wasn't good enough. The mobile phones that we were trying to use then looked like small bricks, and we didn't respond very well, and we didn't have the network capacity. But 2010, coincidentally, was round about the year of the launch of the iPhone, and suddenly we had a piece of technology which we could give to the students, which we knew was actually going to work as a device for them to use in clinical practice. Plus, we got sort of more reasonable 3G networks, all that kind of thing sort of came together. And so, you were seeing our students very much where they were coming from. They were beginning to use apps, they were beginning to use iPads and iPhones, there was still hardwired computers in the ward, which, to be honest, it's very difficult for a student to actually get any time on that, because they may well be a hardwired computer on a drugs trolley, or the ward administrator trying to use it. So, the actual possibilities for them to get connectivity was quite small. But they were beginning to think in this technology way, and carry devices with them. So why mobile learning? Well, it's all about helping those students become better doctors. It's all about helping them learn in clinical practice, putting the responsibility of them to learn. It's about them picking up this near patient experience, and we really don't want them to be standing by the bedside with their phone going, but we do want them to having worked with a patient, to take a step back with the doctor or the nurse and things like that, and ask for feedback. So, the first thing we did was to provide some medical content on the phone. And that's one thing we learned from Alps, was that if you put some stuff on the phone which engaged the student anyway, they'd actually remember to charge it up and bring it with them. Then, if there was opportunities to use it in assessment, it will be there ready. But they love that, so we give them 6 titles, we give them the 2 BNFs, some Oxford Handbook titles, which they use very regularly. They get very upset at the end of 5th year because they can't carry on using them, and foundation year doesn't necessarily give them, although there are a few foundation schools, I think, giving that sort of content now. So go and do your F1 in London if you want. But you know, we're providing them with a number of assessments that they completed, things like mini CEX, and also, you know, providing them the way of recording that assessment on the phone and sending it through into their portfolio. And their portfolio was Myprogress. Probably covered that. We gave them some mobile broadband connectivity as well, just because there are some hospitals and some GP surgeries that really can't, certainly in those days, couldn't get, you know, wireless connection or anything like that. So still are some, unfortunately. But Airedale Hospital, which is the other side of Keighley, is sort of in the country, and it's sort of in the wilderness when it comes to telecommunications. You know, they have a clinical network, and that's it. You can't get a signal on your mobile. You can't get mobile broadband. You can't, and they have clinical wireless that they only let clinicians on too. So you know, it's still a bit of a challenge. So mixing that availability of communications is really important as well. Lots of medical content. I mean, to be honest, 5 years ago we were looking at what device to choose, and the iPhone was a nice phone, but also you had things like the App Store, and people are beginning to develop really useful medical content that would go on the App Store. You know, especially, and that's increased, especially with the launch of things like the iPad. You know, has generated people's ideas about what kind of apps they could write for this. So I think the richness of apps is definitely in that. Although, you know, clearly most developers now will do developments into both Apple and Android. So our apps for learning is the first thing we gave the students is a reflection tool. You know, and this is very simple. It's a very simple note taker. It means students don't actually have to write things on the back of their hand and try and remember them. They can actually type a note into that, and they can send it straight back into their portfolio, into an area of Myprogress, which they can start to build up bits of evidence. So, you know, they might just say, I saw a particular condition today, I must remember that the, you know, treatment for that is so and so, and they can start to build that up over time. And one of the things that doctors really have to do all the way through their career these days is provide evidence to support applications. So when they come to fourth year and start applying for foundation year jobs and things like that, they actually can build up in Myprogress a whole set of evidence that they can use to support that application. Because, you know, I mean, part of our job as educators is to convince people to do that. And the students who really do that and get it say, oh, I'm glad you made us do that, because, you know, without a bit of push behind this, we wouldn't have done it, and then we wouldn't have any of this evidence that people are asking us for. So it's about generating that culture of reflection and note-taking and keeping track of things that are happening in their career. The next bit was around giving feedback, and with my knowledge map we developed some versions of the Minicex app, which we could then use to capture any feedback that a doctor might give a student. Sorry, that shows the patient, but we haven't actually done patient feedback directly yet. And you know, this assessment tool, like Minicex, it has various sections that are used to assess there, but the important bits here are the ability to capture the assessor's feedback immediately, for then, once that's captured, for the student comments then to be entered. So, you know, that might be the assessor's feedback, and the other bit would be the student's action plan. You know, I will go away and practice this, will you assess me again in a week's time? And and all this immediately gets, providing you can get network connectivity, you can send all these assessments straight away into Myprogress and into their portfolio. Now that sort of collection of data and collection of evidence and all this kind of thing is starting us to think very much about the transition from undergraduate medicine to postgraduate medicine, and how we do that, how students don't necessarily lose all this information if they want to keep it and so on. So that was 2013-14, so that was 10,500 pieces of assessment, formative assessments through Minicex for 4th and 5th year students. And you know, the students are they're very demanding in terms of feedback. And if you look at the National Student Survey, the worst bit of the National Student Survey is always feedback, because students never understand quite when they're getting feedback, I don't think. You know, they come and say, you never give us any feedback, and we say, well, yeah, what about all that? Because that's about 20 to 25 mini CX assessments in clinical practice for each student. So you say, well, you know, don't you think that's feedback? You know, but still they want more and more and more and more feedback. So feedback is very much where we get a lot of pushback from the students. But we are doing that. We've done slightly less this year, because what we've tried to do is to not worry so much about quantity, but worry a bit more about the quality of the feedback. And we sort of say we'd rather have a tutor give the student a good quality feedback, and have a good quality action plan for the student, than necessarily just doing it for the sake of doing it. And sometimes that happens. Over 5 years we've developed to the point where people are saying, well, we've developed the quality of feedback. When we first started, it was, yes, I've got some feedback. And you think, well, was it good feedback? Did you give good feedback? Was it useful? And that's just some more of the data behind it. The other thing we've done is use what we call the learning suite, and which is probably the Myprogress app now, is it? Yeah. It's the same thing, we just rebadge it. But we use it for feedback from the clinical placement. So we can create a questionnaire and load it down to the students' iPhones about their experience in a particular placement, and then they send that information back to us, and we can then use that data when we go and do the annual meetings with the NHS about quality of placement and what we're doing, what they're doing. So it forms quite a key part of the NHS university reviews. But I think the key bit here was having a portfolio behind all the medicine side of things. And some of the outcomes, the guy in the middle, by the way, is Sir Alan Langlands, who is Leeds VC, ex-Dundee, isn't it? Yeah, ex-NHS. Yeah. Really useful to have VC who used to run the NHS. But he's really interested in what the students are doing. And he came and sat with them, and this was some co-produced. They were showing him some co-produced content that we've done with the students about OSCE revision and things like this. But this is some of the comments from the clinical teacher. That it formalises the feedback. And I think we get some really good feedback actually from people who have left the university for 2 years and perhaps doing an F2 job now, and they come back and say, we really get the idea of portfolio learning because we have to do this all the time in the NHS, and we really understand it. And some of our colleagues who didn't have to do that in their undergraduate course really struggled with the idea of doing it because you made us do it as undergraduates. It's a natural part of our life. Another F2 guy. And that was about the content. So, I think the sort of success here is that it's sort of changed the way of doing assessment. We do a lot of formative assessment using it, and we also find that the students are quite opportunistic. They say, you know, I've had some bad feedback, I need to go and clinical skills lab rehearse this particular procedure because I'm not good at it. And the doctors use the resource as much, you know, that we find they challenge students. So have you got your phone with you? Can you look up in the BNF what the prescribing rules are for this? Come back and talk to me. And so you start to get that interaction. Now, we've been doing this for 5 years and it didn't happen magically overnight, you know, and it's all happened gradually and more as the healthcare professionals understand why the students are carrying the iPhones and vice versa. And you know, you start to get that working together. So that's a run through of what we've actually been doing. Sorry, I may have taken us a bit longer than.
Yes, of course.
Yeah.
Would you now go for iPad minis or for iPad, full iPads instead of iPhones if you were to go again?
Certainly wouldn't go for a full iPad because I think our feeling is it's far too big to carry around. The iPad mini is probably a good size. If you're wearing scrubs, it fits in the pocket of scrubs, unless you're wearing size small, in which case it doesn't. But you know, phones are getting bigger as well. So you know, the idea of a phone, I think we're still quite favourable because it's easier to carry. It's more manageable in clinical practice. So, you know, a bigger format phone or an iPad mini sort of size is probably the optimum area.
You've been running for a while now and giving out the equipment, haven't you?
Yeah.
How long have you found the lifespan of your devices to be?
Depends on the student, of course. We tend, what we do is to buy devices for the entry into 4th year, and then they give them back at the end of 5th year. Sort of like now, we've got boxes of the things, you know, coming back. For some of those, they're definitely end of life. You know, for some, they look pristine, and we keep, and what we've done is to say, well, we'll keep the good ones as spares, and then, you know, for the next year, if somebody drops it, you know, quite a few people manage to drop it down the loo, which is a bit fatal for some of these devices, you know.
Wouldn't happen with an iPad. Don't go down the loo.
Yeah, but they still flush it. You know, but I would say 2 to 3 years is a good lifespan. I mean, I think what we are finding now, though, is that, and it's sort of interesting that the way technology networks is changing is that last year we gave some iPhone 5Cs to our students. Now, those have 4G on them, but the contract that we had was free voice and text and 500 meg data. Now, a 4G phone can soon use that bandwidth up because there are all sorts of apps out there that says, oh, you're on 4G, have the high resolution version of this. Let's use your data quota up quickly, you know. So you know, but the voice element of it is dropping off quite rapidly. People seem to have forgotten how to speak to each other or text each other. They're just using Twitter and LinkedIn and Facebook, and it's all data capacity now.
Okay, thanks so much, guys.